Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for the EHA conference coverage, Clinical Clips in Myelofibrosis. My name is John Mascarenhas, and I'm a professor of medicine at the Icahn School of Medicine at Mount Sinai and the director of the Center of Excellence for Blood Cancers and Myeloid Disorders. In this clinical clip, I will provide expert interpretation of new and emerging data on the pathophysiology, diagnosis, and treatment of myelofibrosis presented at the 2024 European Hematology Association Hybrid Congress in Madrid, Spain. So the first study we're going to cover today deals with MANIFEST-2, which was a randomized phase 3 study of pelabresib, the pan-BET inhibitor, in combination with ruxolitinib versus ruxolitinib alone. And it's first important to sort of set the stage and understand the relationship between JAK-STAT signaling and BET proteins, and the synergy possibly by blocking BET proteins in terms of abrogating aberrant megakaryocyte differentiation, erythroid differentiating, and reducing this pro-inflammatory cytokine production that drives the disease process and contributes to the bone marrow fibrosis and disorganized stromal environment that ultimately leads to extramedullary hematopoiesis through aberrant stem cell trafficking. So the splenomegaly, the hepatomegaly, the cytopenias, and ultimately the systemic symptoms that burden our patients with myelofibrosis. So the MANIFEST-2 compared ruxolitinib plus placebo versus ruxolitinib plus pelabresib in a randomized phase 3 setting in patients who were intermediate or high-risk disease and JAK inhibitor naive. And then we're looking at biomarkers. There was significantly further reduction in biomarkers that are inflammatory and known to drive the disease. Those are NF-kappa B regulated gene sets, particularly IL-6, IL-8, and TNF-alpha, were all more significantly reduced with the combination of pelabresib with ruxolitinib than ruxolitinib alone. We also saw from other biomarkers that there was an improvement in terms of reduction in reticulin fiber density, distancing of megakaryocytes, CD61 stained megakaryocytes, and an increase in CD71 erythroid progenitor cell proportion. So also tying in with the clinical benefits that we saw in terms of improvements in anemia. And there was a significantly greater reduction in JAK2 V617F VAF at week 48 with the combination compared to ruxolitinib alone. Importantly, when pelabresib is combined with ruxolitinib, we did not see significantly increased toxicity concerns. So there was a more frequent treatment-emergent thrombocytopenia profile, also dysgeusia and diarrhea that was mostly grade 1 and 2 and transient in nature and rarely led to dose modification or dose discontinuation. So this was a really well-tolerated combination partner with ruxolitinib. In fact, there were less grade 3-4 treatment-emergent adverse events in the combination arm and the single agent arm. This likely leads to potential in paradigm shift of treating patients with myelofibrosis, moving away from single agent ruxolitinib to combination strategies with pelabresib, and follow-up data at week 48 and beyond is expected in the near future. The second abstract we're going to cover is that of pacritinib, which is a selective JAK2, IRAK1, ACVR1 inhibitor that spares JAK1, and this is a drug that's now approved in the U.S. for patients with myelofibrosis with platelet counts less than 50,000, but is NCCN endorsed for patients with any platelet count after ruxolitinib failure, or because of its ACVR1 inhibition potential for patients with anemia as well. So here we did a retrospective study looking back at outcome measures of spleen response, symptom improvement, PGIC, patient global impression of change, as well as transfusion independence with pacritinib-treated patients versus BAT at week 24. And you can see in each case, pacritinib was superior to the BAT arm, which was, in half the cases, low-dose ruxolitinib, was superior across all these outcome domains, including transfusion independence. And this has been linked again to ACVR1 inhibition and modulation of hepcidin expression as a means of controlling iron availability for erythropoiesis. On the right, you'll also see that no matter which domain of symptoms one looks at, pacritinib outperformed BAT when looking at physical function symptoms, spleen-related symptoms, and cytokine spleen-related symptoms. We also looked at the role of monocytosis in myelofibrosis patients treated with pacritinib versus BAT in the PERSIST study. Monocytosis is a recognized adverse prognostic marker, and patients with CMML may be an interesting and appropriate patient population to treat with pacritinib. So in this study, we divided the patients based on whether they had monocytosis versus did not have monocytosis in purple and in blue, respectively. And you can see that there was really no difference, despite its adverse prognostic influence in terms of spleen volume reduction. In fact, if anything, symptom reduction was better in those patients with monocytosis, but generally the patients did just as well with pacritinib, even with the presence of this adverse prognostic marker of monocytosis. On the right, if you look at the change in hemoglobin over time, the majority of patients had an improvement in hemoglobin over baseline rather than a decrement with pacritinib, even in patients with monocytosis. Further looking at the impact of pacritinib treatment on symptoms in patients with thrombocytopenia who require red cell transfusion. So this is looking at patients who have both thrombocytopenia and anemia. And again, making the point that pacritinib in blue at 200 milligrams twice daily, the approved dose, when compared to BAT in gray, or even just those patients from BAT that got low-dose ruxolitinib, was superior in terms of improvement in physical function symptoms, spleen-related symptoms, and cytokine-related symptoms. In another abstract, looking at real-world treatment patterns and outcomes in patients with myelofibrosis treated with pacritinib in the U.S. Again, it's approved for less than 50,000, but can be used and endorsed by the NCCN irrespective of platelet count, particularly in patients who have failed prior lines of therapy. And that is exactly what we're looking at here. So in this retrospective study of outcomes, we were interested to understand what were the outcomes of patients who had both thrombocytopenia and anemia. And you can see this was subdivided by and color-coded by number of prior lines of therapy, and then depth of thrombocytopenia, and then stratified by hemoglobin greater than 8 or less than 8. And then the take-home message are the plots on the right or in the middle, really showing that, irrespective of the baseline platelet count on top or hemoglobin on bottom, there was stability over time in those patients treated with pacritinib in real world in platelet count and hemoglobin. And in fact, over time, you can see an improvement in median platelet count and hemoglobin in those patients treated with pacritinib, sort of, again, providing confidence in the ability to deliver this drug safely in these patients with even dual cytopenias, and that there was no significant reduction in outcome, despite the fact that both anemia and thrombocytopenia are well-recognized adverse survival outcomes. This did not impact outcome in an adverse fashion in patients treated with pacritinib in the commercial space. The next abstract that we're going to talk about, I think, is a very important abstract in the setting of patients with polycythemia vera. This was presented by Jean-Jacques Collagen, and this is data coming from the studies with ropeg interferon versus best available therapy, which is mostly hydroxyurea, and long-term follow-up from the CONTI-PV study, which ultimately led to the approval of ropeg interferon. And this was looking at the relationship between molecular response in JAK2V617F reduction and event-free survival, which was defined as thrombosis, progression to MF or AML or death. And you can see that there was a difference in patients that were treated with ropeg interferon versus ropeg interferon that had a response, a molecular response, versus those that did not in blue in terms of this outcome measure of event-free survival. So it's a composite outcome measure, but it's an important measure for patients with PV that are worried about these thrombotic events and progressive events, in which the attainment of a molecular response with interferon did translate to improved event-free survival. So more data demonstrating, in addition to data we have previously with ruxolitinib in PV through the MAGIC PV study, that molecular responses matter, and even a 50% reduction in JAK2V617F VAF can correlate with an outcome measure that matters to patients, such as event-free survival. The next abstract we're going to talk about is a novel drug called elritercept, otherwise known as KER-050. This was a study that was led by Claire Harrison called the Phase 2 Restore study. And this is a drug that inhibits activins as well as important growth-derived GDF, growth-derived factors that are important as TGF-beta superfamily members in modulating normal hematopoiesis, erythropoiesis, and even thrombopoiesis, and mediating the tumor microenvironment and fibrosis. So a drug that targets and inhibits these molecules, these signaling molecules, could improve erythropoiesis, thrombopoiesis, reduce fibrosis, and potentially even impact splenomegaly through extramedullary hematopoiesis. And the Phase 2 Restore study was looking at this drug given subcutaneously every month in patients with myelofibrosis who were either on ruxolitinib or off ruxolitinib, who had anemia, and were treated with this drug in dose escalation cohorts, looking for a recommended Phase 2 dose, which was ultimately determined. And what this study showed was that from a biomarker perspective, there was clear evidence of improvements in erythropoiesis by improvements or increases in soluble transferrin receptor percentage, reticulocytes, and ultimately hemoglobin. So this drug was able to improve hemoglobins and reduce transfusion burden in this early look at this dose escalation phase before it expands, and was a very well-tolerated drug with minimal side effects, and even had improvements associated with it, both from a symptom perspective and spleen perspective, suggesting that this drug may do more than improve anemia and thrombocytopenia, but may also affect the bone marrow function and ultimately the consequences of extramedullary hematopoiesis and symptomatology. Therefore, it was deemed a safe and well-tolerated drug, and will move forward at its selected recommended Phase 2 dose in an expansion phase, which is eagerly awaited for results in the future. The next abstract we're going to talk about was presented by Dr. Celia, and this is I would say an important abstract that brings in the biology and the recent understandings of the mechanisms that drive myelofibrosis, and much of it has come from her own laboratory, dissecting out the contribution of the stromal cells, particularly mast cells and basophils, and the production of TNF-alpha that drives the NF-kappa B pathway, which is a pathway of interest and a target for drugs like BET inhibitors, that ultimately culminates in the overexpression of galectin-1, which has previously been shown to be an important modulator of inflammation and the suppression of anti-inflammatory responses. And likely plays a role here as it was dissected out as an important mediator, both in murine modeling and in human cells from patients with myelofibrosis, significantly upregulated, driven by TNF-alpha, driven by these stromal cells. And in her modeling, when using a blocking antibody, regress the fibrosis and the extramedullary features of the disease, suggesting that this is really not just an important molecule, but a targetable molecule that will likely translate into clinical trials targeting galectin-1. Again, a downstream marker, NF-kappa B, driven by TNF-alpha, creating this perfect storm that continues to self-perpetuate the clone through this inflammatory circuitry. The last study we're going to talk about is an important study in the context of transplantation for myelofibrosis. This is a study from the German group, looking back retrospectively at over 80 patients who received a reduced intensity conditioning transplant for myelofibrosis with busulfan conditioning, and separating the patients and their outcomes based on whether they ever received pre-transplant JAK inhibitor therapy or received only pre-transplant reduced JAK inhibitor therapy, or peri-JAK inhibitor therapy, so pre and post for almost a month after transplant. And this is important because we often use JAK inhibitors en route to a transplant, and there's conflicting data on to the extent in which a JAK inhibitor actually improves transplant outcomes. I think most of us recognize that intensive pre-transplant JAK inhibition reduces spleen, inflammatory markers, improves performance status, and likely makes patients a better candidate for transplant. But what this study demonstrated, looking at biomarkers through the treatment period, was that there was an advantage to peri-transplant JAK inhibition. So also demonstrating that peri-transplant JAK inhibition was associated with improved or greater immune reconstitution with B cells as well as gamma delta T cells and NK cells with less acute GVHD and less risk of relapse. So for the first time, and again, retrospectively, in a relatively small cohort of patients, it would appear that there is a benefit over pre-transplant JAK inhibition, and definitely over no JAK inhibition in terms of this peri-transplant JAK inhibitor approach. And in this series, most of the patients received ruxolitinib, but there were patients who received fedratinib and other JAK inhibitors. So it really, I think, enforces the idea that we really need a prospective study comparing the use of peri-transplant JAK inhibition to improve our transplant outcomes for those patients with myelofibrosis that go on towards this, the only, this modality that offers the only potential for cure in this disease. So thank you again for joining us for the EHA conference coverage, Clinical Clips in Myelofibrosis. Please be sure to click on the landing page for this activity to claim your AMA, ABS, ANCC credit, access downloadable slides, as well as other topic segments and case scenarios. Thanks very much.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.